Hello, my name is Dr. Keith Stewart. I'm here in Edinburgh at our Myeloma 2017 meeting. We've just finished our first day of sessions. I'm joined by Dr. and Professor Gareth Morgan from the University of Arkansas in Little Rock, United States, and by Professor Leif Bergsagel, a colleague of mine at the Mayo Clinic. And we're just going to do a quick recap of what we've been discussing today. And perhaps I'll start by asking you both what the highlight of the day was for you at the meeting. And maybe Gareth, you could start.
So I think for me, really the CAR-T treatment, all in one place, and the role of CAR-Ts manipulating the immune system and using bispecific antibodies to fix the immune system, or T cells specifically, to the malignant cells, and how it looks really exciting for the next few years that CAR-Ts really are going to be effective clinically. They're really going to bring patient benefit. And we have another approach to do it, which are these bispecific antibodies. So one of that combination of therapies is going to work out, one or more of them actually. So I think it's very exciting for patients.
There was discussion about CAR-Ts, but also about things called BiTEs and bispecifics. What did you take away from that? Is the target the important thing, or do you think the delivery system is the important thing?
So the target's important, and so there was discussion of CD38, BCMA, SLAM-F7, all these potential targets. I think the target is going to be important, but the delivery system and the practicality of delivery, when an antibody, CAR-T was approved today for B-cell lymphoma, $375,000. The previous one, $500,000. So these advances are going to come at a price, and there'll be an issue around which population and where do we use them.
Leif, what was your...
Yeah, well, I would second Gareth. I think the CAR-T cells were really exciting. And in fact, in his presentation this morning, Gareth gave a suggestion of places where we might introduce these things if we can identify the right patients, the patients that have really high-risk disease, and it's clear that they're not benefiting from what we're doing today. Maybe very soon in the future we'll be able to introduce these new therapies. In particular, Gareth mentioned patients who had lost all function of a gene called P53, is doing very poorly, and where we might think about introducing these early.
So I was very taken with Professor Einzel's presentation, because he showed for the first time, to me at least, that it wasn't just CAR-T cell therapy that could work, but it could also be with these very small antibodies we call BiTEs. And he showed at least 3 patients in their trial that responded. What is your thinking about the success rate we're going to see with those?
So I think it's going to be a big old fight between them. They target the same antigens, and one is somewhat easier to produce and get to patients than the other, which involves, a factory biologically modifying stem cells or biologically modifying T cells, and then introducing them back into the patient. The use of a retrovirus, lentivirus, to modify the cells. We heard from a German group where they were using Sleeping Beauty approaches, which is a great name, and somehow or other they were managing to use Sleeping Beauty to modify the T cells to recognize the tumor cells. And although it sounds futuristic, it's actually really quite a safe and valid approach, I would say, that would do for the regulatory.
It was all faster, wasn't it?
Yeah.
I was quite taken with the idea of combining different immunotherapies. So there was talk about combining them with daratumumab, which activates T cells apparently, with oncolytic viruses, with checkpoint inhibitors. What was your takeaway?
I think it's kind of encouraging, in fact, that they haven't seen very much resistance or relapse so far to CAR-T cells. But there's anecdotal evidence in other tumors where they could use a checkpoint inhibitor to reestablish sensitivity, but to wake up the T cells that may have fallen asleep. Mm-hmm. So I think there's a lot of promise for that.
We talked a lot about genomics today as well, and of course you're both world experts in this. What was your what did you walk away with today that was new? In fact, let me ask the question. Lead the witness. We talked about how in non-Hodgkin's lymphoma there's a phenomenon called double hit lymphoma that is treated quite differently than a lymphoma that doesn't have that double genomic hit. And we talked today about whether that might exist in myeloma and if we should start calling it that. So do you want to comment?
Well, I should say it was your idea to kind of coin the double hit thing, which I think is a really good description of it, and it fits with what the terminology is in large cell lymphomas. So a double hit myeloma may involve biallelic inactivation of p53 and amplification of the locus CKS1B occupies on 1q21. And the combination of that, you can define a population of 6% of the total of myeloma that has an absolutely dire outcome. And I think you could even think of going to regulators with this kind of idea. It works in a test and validation cohort. And, you know, I think it's really something that I felt the room supported and thought was a good way forward.
And we're not really tested for it today is the problem, right? It's still in the research domain, but the testing is becoming available now clinically.
Yeah, but as all of the academic centres have their own diagnostic sequencing panels, and it's basically an adaptation of that type of technology that's freely available and we all know how to use, that I think really would allow us to get something that could take 10 years to go from the relapsed refractory setting to this maybe 10% of newly diagnosed patients that would really benefit from it. And a molecular diagnostic for the first time would allow us to shortcut that 10 years and get it to people up front where they really need it.
It seems like so long ago, but we started the day with what I thought was one of the most exciting sessions, which was the concept of not using bone marrow testing in myeloma, but using the peripheral blood or liquid biopsy to at least eradicate bone marrow after the first diagnostic sample. I was very taken with that and thought it was very exciting. So Leif, tell us what we learned.
Yeah, well, you know, it's interesting because multiple myeloma is called multiple myeloma because there's multiple bone marrow tumors spread throughout the body. However, typically when we do the diagnosis, we take the sample from the iliac crest, and it doesn't necessarily represent all the sites of disease elsewhere. However, if we look at the circulating tumor DNA or the circulating tumor cells, then we can get a picture of what's going on everywhere in the body, and I think maybe capture variants that are poor prognosis and know about them earlier. So it seems very feasible. It may miss, it's probably not good for measuring minimal levels of disease, but for following disease and particularly following bad disease variants, I think there's a lot of promise.
Gareth, you maybe take a bit more convincing, I suspect.
No, I thought Jens Law gave a great talk. I think the technology is very convincing. I think it, again, is translatable to panels in everybody's hands. I think, though, it needs to be used in the context of an imaging modality as well. Currently we put needles into disease sites to assess what's going on there. But I think if you used the peripheral blood wisely with imaging, you might have a universally applicable whole body approach to assessing the molecular makeup of myeloma. And I'm completely on board with it.
We'll learn more about imaging tomorrow at this meeting.
I
did want to close with just a comment on amyloidosis, because I thought we had an exceptional speaker on amyloidosis today.
Did you like the picture he showed of the macrophages eating the amyloid fibrils? It was great.
It was the video. So what Dr. Wickellicker actually did is give us a 20-minute tour de force on all of the exciting things that are happening in amyloidosis, from treatments to imaging to completely novel therapies, and I didn't want to close without mentioning that. So today we've heard that bone marrows may become less common. We can use peripheral blood testing. We learned that there are fantastic advances in immunotherapies, particularly with CAR T cells, which are working at a very high frequency in myeloma patients. And we learned that our experience and knowledge of genomics is maturing, and that we are now in a position, we think, to define a completely distinct group of myeloma patients that need different therapies. I hope you've enjoyed listening to us, and we'll see you again tomorrow.